Welcome, everyone. Thank you for joining us for today's CITI program webinar. Today's topic is research with audiovisual mobile data collection tools, ethics and regulations, and will be presented by Dr. Ethan Larson from the Children's Hospital of Philadelphia, Mr. Jacob Coleman, Dr. Faisal Masood, and Dr. Farzan Sahsangohar, all from Houston Methodist Hospital. Let me share an acknowledgement from today's presenters for their article in the Ethics and Human Research Journal. About today's presenters, Dr. Ethan Larson is a human factors engineer at the Children's Hospital of Philadelphia in the radiology department. His current research focuses on the intersection of human factors with patient safety and health informatics. In addition to research, he also serves as a member of the quality and safety team for radiology. Jacob Coleman is a scientific writer at the Center for Outcomes Research, Houston Methodist, and at Texas A&M University. Mr. Coleman obtained an MA in philosophy from Rice University and a BA in English and philosophy from Austin College. His research interests include research ethics and epistemology, medical professionalism, and publication ethics. Dr. Faisal Masood is Medical Director of Critical Care at Houston Methodist, Vice Chair for Quality and Patient Safety, and Medical Director of the Cardiovascular ICU at Houston Methodist Vakey Heart and Vascular Center. He is a professor of anesthesiology at Weill Cornell Medical and of anesthesiology at Houston Methodist. Dr. Farzan Sahsangohar is an assistant professor in industrial and systems engineering at Texas A&M University and an assistant professor in the Center for Outcomes Research and the Department of Surgery at Houston Methodist Hospital. He received his PhD in industrial engineering from the University of Toronto. And now I'm going to pass the mic to you, Jacob.
Thank you for that introduction, Jamie. My colleagues and I have no relevant interests to declare. Our learning objectives today are to identify ethical, regulatory, and liability issues associated with research using audiovisual data collection, to explain the role of participatory engagement in informing study design and facilitating study conduct, to understand the roles of technological limitations and environmental context when collecting data with mobile devices, and to describe the role of organizational readiness in implementing video recordings in highly confidential settings such as a hospital environment. We have divided discussion into 4 parts. I will begin by covering background ethical and regulatory issues, and then my colleagues will discuss lessons from a specific case of conducting audiovisual research in terms of participatory ergonomics, data collection, and organizational readiness. Drilling down further to the AV specifics, video can capture data that the researchers don't even need for the study objective, but that also cannot be easily avoided. This contrasts with many other forms of data capture. For instance, if a data-driven researcher pulls data from an electronic health record, then they, or an intermediate data steward, can be selective about which fields to include, for instance, leaving out names or medical record numbers. A field observer, although exposed to all of the information in the room, can likewise be selective about which notes to take and can inform those present about the focus of the observations. But AV has no selective attention. All information in the frame is retained, including faces, health information, conversations, bystanders, and passerby visitors, etc. Redaction is technically harder and may require spotting unusual context clues, like blurring a unique tattoo, which can increase the risk of re-identification. The status of bystanders as subjects should not be underestimated. A research subject is defined not by the objectives of the research, but by how the research-specific interventions or intrusions affect people. The common rules definition, particularly the bullet number 2, applies to audiovisual capture, as you obtain identifiable private information, even if you do not intend to use it.
So as previously mentioned, this webinar is based on a recent publication that documented a recent study in which we used an eye tracking device in an intensive care unit. I'm going to start by providing a bit of background about the study and the motivation behind this study. What motivated this research was the prevalence of burnout among providers, specifically in intensive care units. A 2019 report from the National Academies of Sciences, Engineering, and Medicine documented alarmingly high stress rates and clinician burnout in the United States, and our hospital was no exception. Burnout is defined as the prolonged response to chronic interpersonal stressors on the job, according to Maslach and Leiter. We were interested in identifying these major stressors among our ICU nurses in our hospital and more importantly, investigate how it builds up over time?
So I was working as the postdoctoral fellow engaged in actually collecting a lot of this data for the study and in the ICU with the nurses. And so I am going to be going over our issues and solutions we faced when actually engaging in data collection for this study. So in the process of actually engaging our participants in the study, the nurses were unsure of what we were actually seeking to do when we first approached them with the ideas for how we wanted to do this. And there was a lot of skepticism about the study, in large part due to a lot of the concerns that Mr. Coleman indicated about the nurses and the liability and protections as they would have after wearing what really constituted a video camera documenting their activities for their entire 12-hour shift. They were concerned that we were going to be in their space and were assessing their work, which we actually changed our verbiage that we briefed everyone on to make sure to make clear. We are a research team. We are all engineers. We are not medically trained, and we were not going to be assessing their work, nor were we going to be allowing their supervisors to assess any of the video data collected. And so we made efforts to be present in advance of the study launch. We actually went in for shift change at the morning and the afternoon with the devices to introduce ourselves, to show off the equipment, and to just generally answer questions. And we held a couple of in-service sessions, which are mid-shift training and education periods that the nurses can engage in, just so that we could explain ourselves, be a familiar face, so that the first day that we showed up, it was not an unexpected presence. Mitigation strategies for using mobile audiovisual recording. We made it very clear to our participants that we were there to support them, that we were. At this point, I'm going to hand it over to Dr. Faisal Masood, who is going to discuss the importance of organizational readiness in supporting such a study.
Well, thank you. I think this is the point which is very important, recapping and really encompassing why did we even do all of this work in this study. We have to recognize that we are in a journey of a high reliability organization. And let me and make the audience aware what exactly is a high reliability organization. High reliability organization are organizations which really make an effort and avoid catastrophes and major challenges and major mishaps. And some of the key examples are airline industry and nuclear industry. So how do the high reliability organization impact? So there was some guiding principle, and I'm going to share with you all. For example, the first is preoccupation with failure. That means they're looking for things which will break down. And you have to recognize that in a hospital environment, and especially in an intensive care unit environment, these are the most complex technologically, most complex patients, and there is a turnover of shifts of nursing workforce every 12 hours. So there is so much elements of challenges, mistakes, fatigues, which can happen. And if we're not looking for things to fix, big mishaps and wrong care can be given to the patient. Second principle of high reliability organization is reluctant to simplify. If people are looking for easy fix, they are not there. There are much more things at play, and we have to understand that. Third principle is sensitivity to operation. That really it comes from the front line. And who better is front line than the nurse who is interacting with the patients, doctors, everybody. So they are the key, I would say, of work.
Thank you, Dr. Masood. So in summary, what we have gone over today are the ethical considerations of audiovisual data collection occurring at multiple levels from the general to the specific based in research norms, surveillance norms, and norms specific to study settings. We've looked at engagement and clear communication with stakeholders, including IRBs, participants, and institutional leadership, which informs the design of the study. We've looked at the design and conduct of AV-based research, which should account for technological capabilities and potential failures. Mobile AV data capture does raise additional technological challenges and modifies the options normally available for ethical study design.
I also invite everyone to review our content offerings regularly as we are continually adding new courses and webinars in various areas of research, ethics, compliance, and professional development. You may be interested in our course on tech ethics and regulations, which is continually updated with new modules to cover emerging topics.